managers. Thank you for including this team on the agenda today to present the Skin Cancer and Early Detection at Colstrip Medical Center Quality Improvement Project. I'm Jenny Belt. With me are Kirsty Downing and Catherine Troxel. We are all bachelor's prepared registered nurses for Montana State University. We have 4 objectives today. First, we will identify that there is a skin cancer prevention and early detection gap in care at the Colstrip Medical Center. Second, we will introduce a quality improvement project aimed at closing this gap by providing relevant education to patients served at the clinic. Third, we will discuss outcome measures for the proposed QI program, which will help evaluate the success of the program. Fourth, we will rally this team for guidance, support, and funding for the implementation of this program. In 2021, the CMC mailed out patient satisfaction surveys. 1,800 surveys were returned. Of those, 378 patients, or 21%, as depicted in Figure 1, cited a lack of skin cancer education or screening at their annual office visit as a dissatisfier related to their care. CMC sent a follow-up survey to 150 random patients to identify specific gaps in care. From the survey, we learned that patients are not aware of or consistently practicing primary and secondary skin cancer prevention and early detection strategies at home. To better understand cancer in Rosebud County, we look to the Montana Central Tumor Registry for data and statistics related to cancer in Montana. According to the registry, melanoma is the 5th most common cancer in Montana. It accounts for 2.2 patient deaths per 100,000 people annually. There are 380 new cases every year, and 95% of all cases are caused from UV light exposure, which is a modifiable risk factor for cancer. Therefore, and in theory, 95% of all melanoma cases are preventable. We focused our attention on a knowledge or education-based skin cancer prevention program at our rural Montana clinic. The overall aim of this project is to decrease the incidence of skin cancer in our community by educating our patients about skin cancer prevention and early detection strategies. Specifically, our focus will be on reducing UV light exposure at home via physical and topical measures and utilizing self-skin exam to detect skin changes early and seek early care. We wanted to create smart outcomes that were specific, measurable, attainable, and reasonable with a time frame. Specifically, we hope to achieve an average 20% decline in our patient's sun exposure behavior inventory score over a 2-year period, and we hope to see a 300% increase in the number of patients performing a self-skin exam on at least an annual basis by the year 2025. The conceptual framework used for this project is the Planned Use Study Act framework. The beauty of the PDSA cycle is its repeating nature, which allows users to identify unforeseen challenges and unintended effects of the plan or project. After identifying the unexpected, PDSA allows users to adapt the plan to account for obstacles. You can see the cyclic nature of the PDSA framework in Figure 2 on the right. During the plan phase, users identify problems, ask questions, predict outcomes, and plan. During the do phase, users execute the plan. During the study phase, users evaluate outcome data and compare data to expected outcomes. During the act phase, users will adopt change or establish a new PDA cycle with new goals.
While researching our topic, we discovered little to no evidence supporting the use of asymptomatic skin assessments during primary care visits. According to the AAD, the best way to prevent skin cancer is to protect against UV radiation using techniques such as using sunscreen while outdoors with the appropriate SPF, wearing protective clothing, limiting the time one spends outside and seeking shade when possible, and avoiding tanning beds. Additionally, self-skin exams allow a person to become familiar with their skin and notice subtle changes over time. Some patients are at a higher risk than others for developing skin cancer. Current family practice guidelines identify risk factors as those listed here on the slide. The U.S. Preventative Task Force recommends that all patients 6 months to 24 years of age with fair skin to be provided with preventative education. Those with fair skin over the age of 24 should receive education as determined by their primary care. Resources used to support our project include the CDC, NCI, AAD, and Skin Cancer Foundation. We also used multiple scholarly articles that provided supportive evidence. After researching this topic, our group decided an education program would be the most appropriate intervention. Tools required to gather baseline data and evaluate current processes include gathering data on current care provided through the EHR, applying for information on our specific county cancer trends through the Montana Central Tumor Registry, sending out an initial survey to active patients of CMC to determine patients' perception of the education they are currently receiving, and creating a fishbone diagram to evaluate the current utilization of skin cancer screening at CMC. The interventions required to initiate the program implementation involve organizing a multidisciplinary group titled the Skin Cancer Prevention Committee. The committee and all providers will complete education modules developed by Billings Clinic Dermatology so that they can be up to date on the most current guidelines and practices. Support staff will receive training on the implementation process and the expectations that the administration determine are required for the evaluation tools for each patient. We will integrate the Skin Exposure Behavior Index and Self-Skin Check Survey to assist with data collection. The education will then subsequently be provided to each patient at their annual wellness visit, and they will be provided with CDC handouts as well. The evaluation tools that will be used for our program include the Sun Exposure Behavior Index, which is a Likert-style questionnaire that evaluates current behaviors of patients, and they are provided a score that ranges from 0 to 210. A simple question asking whether patients are currently performing self-skin checks, and if so, how frequently, was also added to the questionnaire. These questions were given to patients at each of their annual wellness visits. Colstrip has a few unique cultural and population characteristics that need to be taken into consideration. The first being that the clinic services a multitude of patients who are farmers and ranchers. This increases their occupational risk for exposure to UV. The majority of patients seen at CMC for primary care identify as Caucasian or white, which is already a known risk factor for the development of skin cancer. However, CMC also sees a sizable American Indian population, considering they are located near the Northern Cheyenne Reservation. The incidence of melanoma is 75% less in this population compared to their counterparts, which may affect data collected regarding program outcomes. Finally, Colstrip is in a secluded location. Billings is an hour and 45 minutes away. This creates a huge disadvantage for patients needing specialty care and can be impacted also by the lack of transportation and inclement weather.
Now we will take a look at the PDSA cycle for this intervention. During the plan phase, the clinical team will review current skin cancer prevention practices at CMC and incidence of skin cancer at the county level. The intervention will initially be trialed with one family practice provider at CMC. The team will identify an established measurement tool to guide education and monitor for improvement. As Kirsty just described, that'll be the SEBI survey. The team will complete skin cancer education modules through the CDC, and the provider will additionally attend a skin cancer prevention training provided through Billings Clinic. The intervention test group consists of 20 patients, age 18 and up, who are scheduled for annual wellness exams and agree to maintain care with the same provider for at least 2 years. The team hopes to observe a decrease in SEBI scores at the second visit, indicating positive behavioral changes regarding sun exposure. In the do phase, the test group will complete the survey at their wellness visit, and then again approximately 12 months later at their next annual visit. Data from the survey will be entered into the EHR for provider viewing and to track change over time. During the study phase, we hope to have a 20% decline in annual SEBI scores and a 300% increase in patient self-skin exams, demonstrating a positive change in patient sun exposure practices. The hope is that implementation of the annual survey does not greatly impact clinical flow or place significant stress on resources. During the ACT phase, if the clinical team achieves desirable results during the trial period, we would like to promote the SEBI survey to other PCPs in the clinic. And then testing change. Next slide. Additional PDSA cycles will be needed to verify the longevity and productivity of this intervention for each clinical team at CMC. Patient education methods may differ from one provider to the next, with some relying on printed handouts versus verbal instruction. This can impact patient understanding depending on their preferred learning method. Clinical team communication between the MA, RN, and provider is critical for appropriate intervention for SEBI scoring and tracking patient progress over time. Intervention goals for established patients will need to be fine-tuned over time as well. Patients may report the same low score multiple years in a row, indicating safe sun exposure behavior. Therefore, should the teams place more emphasis on new patient education? And then on to implementation and spread. The readiness of the primary care clinical teams at CMC will be assessed prior to intervention rollout. Does scheduling accommodate education sessions for staff? Are they appropriately staffed, and do they have a clear understanding of intervention goals? Buy-in from stakeholders is dependent on the success of the provider skin cancer education, resulting in changed patient behavior. Also, funding considerations and proof that the intervention is a productive preventative healthcare method. To ensure spread of the intervention, the improvement team will develop a policy and associated flow diagram to implement the SEBI survey into primary care practice. The SEBI tool will be wrenched into the EHR to facilitate ease of charting and tracking scores over time. Quarterly reports displaying SEBI survey data and provider education focus will be presented at clinic staff meetings and also emailed to provide staff opportunities to discuss successes or barriers to the intervention.
Moving on to the timeline, this is a pretty packed slide. Please note the color coding as it makes the slide easier to follow. You can see that the total projected timeline is 29 months. Pink denotes the Skin Cancer Prevention Committee, which starts meeting in month one. On the timeline, the pink dots show when the committee will meet to review the program's success and make changes as needed. Green denotes staff education, including that for providers and support staff. You can see that the CMC staff education prior to the pilot program for one provider and their staff, and again 16 months later for the entire clinic's rollout. Everything in light blue relates to the project pilot rollout. The dark blue boxes signify the rollout of the entire clinic. In both light blue and dark blue boxes, you can see that the program begins at the patient's annual visit, where they complete an initial SEBI and SSE tool, and that continues through their next checkup the following year. During the nature of the program, due to the nature of the program, it takes 2 full years to collect initial and follow-up data on each patient. The light and dark purple boxes running at the top of the figure describe data collection and reporting. SEBI measures are reported and posted monthly during the full rollout of the program. Total SSE measures are reported on an annual basis. Also included in the timeline are 2 opportunities for improvement via PDSA cycles involving relevant staff during the first month of both the pilot and the full rollout. The Skin Cancer Committee will periodically meet to evaluate opportunities for change as well.
Long-term costs of this program are inexpensive. Initial training and skin cancer education for each clinical team is the most costly piece, primarily compensating staff for their time, which is still under $1,000 per team. Printing physical skin cancer education resources for patients will be the only reoccurring annual cost.
So to discuss outcomes, there are 2 outcome measures. First is the average patient SEBI score, which will be reported and tracked on a monthly basis. The run chart displayed in figure 4 provides a demonstration of what this outcome measure will look like over a 2-year period. Ideally, the average SEBI score will decrease from year 1 to year 2 as a result of the patient education plan. The second outcome measured is the percentage of total patients who report that they complete a self-skin exam at home on at least an annual basis. This number will be reported annually. We hope to see a 300% increase from baseline in the number of patients reporting yes, that they complete the self-skin exam at home by year 2025. To conclude, CMC has an excellent opportunity to make a great impact in our rural community. Ultimately, as a result of this program, we should see a decrease in melanoma skin cancer morbidity and mortality in our community. We feel that patient satisfaction scores will increase after skin cancer is addressed at the clinic. If patients are satisfied with and trusting of our care, then they will return and recommend us to friends and family. The educational tools utilized are inexpensive, which makes the program more sustainable. Thank you for considering our project. We look forward to collaborating with each of you. Please take a look at our references.